If I have a woman with metastatic breast cancer and she is known, or we have found that she's has a BRCA1 or 2 germline mutation that she's inherited, it's very important that we have a conversation about the PARP inhibitors, because in the clinical trials that have been done with olaparib and talazoparib, they were compared to standard chemotherapy. And these women, if they were estrogen receptor positive, had already had hormonal therapy. So the question was to go on to chemotherapy or the PARP inhibitor. Well, thankfully, the PARP inhibitors had better efficacy. They're more effective. They had a higher chance of the woman benefiting from the chemotherapy, getting a response, but also importantly, staying without progression of disease. So staying with the cancer in control for a longer period of time, which of course is extremely important. So right there, they kind of won hands down over the chemotherapy. Then another analysis was done of the Olympiad trial with the olaparib. And this is for women with a metastatic breast cancer, BRCA1 or BRCA2, who were receiving the olaparib as their first treatment for metastatic breast cancer versus chemotherapy. And not only was the response rates higher, the progression-free survival, that is staying without progression of cancer, better, but most importantly, survival was also substantially higher with the PARP inhibitors compared to chemotherapy. So what that told me is, if at all possible, utilize the PARP inhibitor in the first line treatment, the first treatment of metastatic breast cancer, or if you can't use it in the first line, then use it as soon as you can in metastatic breast cancer to get the greatest effectiveness for the woman. The future, I think, is really bright for women with a BRCA1 or BRCA2 mutation that she has inherited, because I think the PARP inhibitors are going to be a big advance in the curative setting for these patients. I think that we'll be utilizing the PARP inhibitors, as a standard of care over the next 3 to 5 years in the preoperative setting before a woman has had surgery, to really see whether utilizing olaparib or talazoparib can completely eradicate the breast cancer, such that by the time she goes to surgery, there is no cancer left. And then she won't need any chemotherapy after that, for example. So that would be great. We await the results of the Olympia trial. This is for women who've already had their surgery. They've had chemotherapy if that was indicated for them. And then half of the women get olaparib and half get placebo for 1 year to see if that will further improve the cure rate. And of course, if it does, it'll become a standard of care. So that's very exciting. The other thing that's going to be happening over the next few years is the opportunity in standard practice to combine the PARP inhibitors with the immune checkpoint inhibitors, which are also developing and becoming available to us clinically as well. But these make a lot of sense to combine together. And some of the early data look like the safety is very good. And we expect that's going to be another excellent advance for women with metastatic BRCA1 or BRCA2 positive breast cancer, but also that's going to move quickly into the curative setting as well. So we really think the immune agents and PARP inhibitors are going to be a very important combination. Treating women with BRCA1 or BRCA2 mutations that they've inherited is the tip of the iceberg for the PARP inhibitors. Many important questions remain about how else we can use the PARP inhibitor. Who else will benefit? Very important. What about women with other inherited mutations that lead to an increased risk of breast cancer, ovarian cancer, or other cancers, such as PALB2, CHEK2, ATM? There are a large number of other mutations that can be inherited. Will the PARP inhibitors benefit those women? What about if a woman does not have an inherited mutation of BRCA1 or BRCA2, but let's say her breast cancer itself has developed a mutation in BRCA1 or BRCA2? Is there a group of those women who may also benefit from the PARP inhibitors? Or what if her cancer has one of the other mutations that can be inherited, but she didn't inherit it, such as PALB2? Will the PARP inhibitors also help her? And then lastly, in women whose breast cancers don't even have a BRCA1 or 2 and they didn't inherit it, for example, but we think it's the kind of breast cancer such as triple-negative breast cancer that might really benefit from a platinum agent such as carboplatin or cisplatin, could the PARP inhibitors be a much safer and better tolerated way to give the woman platinum without giving her platinum, giving her a PARP inhibitor instead? These are very important questions for the future.